Good evening to all of you. I think this is the area which a lot of questions are coming. Let's go through the presentation, and then obviously we'll take up the questions from all of you. So today I will going to present pharmacological management of nicotine use or dependence. Okay, this is the usual slide. As I mentioned, these slides can be reproduced as a whole. Do acknowledge Nimans for the contribution, and any modification you drop an email to us. Again, we don't have any conflict to mention, but only think that the presentation is also based apart from book readings, and some part of clinical experiences are included in the presentation. I'll start with something empower. I think quite you might maybe familiar with this term. Empower is a WHO declaration to curb the tobacco across the world. Now you can see the mnemonics. M is for monetary use and prevention policies. Pre, protect people from tobacco smoke. O, offer help to quit tobacco. Warn about dangers of tobacco. Enforce ban and raise tax. Now, our job as a health professionals or clinician, probably the third one, where you offer the help to quit tobacco. Coming back to smoking, smoking is most important source of preventable morbidity and premature mortality. It kills 5.4 million annually and 10% every minute. So obviously it's highly addictive. If you look at the effects of nicotine, it has definitely some positive effect so far as brain is concerned. Now what are the positive effects? It increases the arousal capacity of the brain. That's why often it's been told that nicotine or smoking is a great finisher. If somebody not able to finish a task and have a smoke, probably he feels more comfortable. It definitely relaxes the body. It enhances the concentration and also works as appetite suppression. Now, brain, what happens? It develops tolerance and withdrawal and makes a craving. So before we go to details about treatment of nicotine addiction, you need to know where it works. Basically, you need to know the targets of pharmacotherapy. Now, this is a basically nicotine acetylcholine receptor, where you can see 2 alpha 4 subunit and 3 beta 2 subunits. So, this is the prime receptor which controls the release of dopamine in the brain. So, nicotine comes and sticks to this receptor, which leads to activation of reward pathway and release of quite a gamut of chemicals. Noradrenaline, acetylcholine, gamma aminobutyric acid, dopamine, and unfortunately or fortunately, this receptor is abundant in the brain. So obviously, this is a normal physiological receptor. Nicotine comes and sits in this site and releases the dopamine. You can see this photograph. So the nicotine acetylcholine receptor, that is NSCHR, which is expressed as a mesocortical-limbic pathway. That is a pathway that reddish color pathway which extends from the nucleus accumbens to ventral tegmental area, extending to the frontal area. This area also known as reward system, and the release of dopamine is associated with reward, pleasure, euphoria, and this is controlled by the stimulation of these nicotine acetylcholine receptors. So if you simplify further, somebody smokes, it goes to reward pathway, activates the tract between ventral tegmental area and nucleus accumbens, releases the dopamine, which goes to which creates a sense of euphoria and relaxation, and being linked to prefrontal cortex, the decision making that should I smoke or should not I use, should I use tobacco now or later, get impaired. So neurobiological basis of positive reinforcing effect of nicotine depends on nicotine binding on alpha 4 beta 2 acetylcholine receptor. This leads to release of dopamine in nucleus accumbens, and this leads to a sense of satisfaction, which is very commonly associated with tobacco use. If I summarize in one line, nicotine from both smoking and smokeless forms of tobacco causes changes in the brain reward circuits that maintains the addiction. So the basic defect lies in the brain reward circuits. Now, because of this type of defect, a person when he wants to quit, he has to basically really struggle between withdrawal symptoms and craving. And these are the two main reasons why a person using smoking or smokeless relapses. Now, if you look at the symptoms of withdrawal symptom, it normally starts in a couple of hours and increases for 3 to 4 days, and it almost goes to a month. And although withdrawal symptom will come down after a month, let's maximum month, but the other part, the craving just goes on and on. So that is a big culprit. The craving for tobacco goes on almost 6 month line, and that's why you see people relapsing so frequently in either first 1 month to 6 months. Along with these two problems, there is another problem in specific to the tobacco. It's like a rapid fire craving. If I can compare in a TV ad, dimag ki batti jala de. It's like just it fires, and which is unique to a tobacco addiction. You don't see in alcohol or other addictions. So those rapid fire cravings are very dangerous, and it just makes the person relapse or lapse. This is a summary table of withdrawal symptom. You can see the gamuts of withdrawal syndrome a person can present. It can be irritable, frustration, anger, anxiety, sense of restlessness, difficulty in concentrating, sleep problem, and obviously a depressed or a dysphoric mood. So these are the withdrawal symptoms. Fortunately, all the symptoms can be controlled in, let's say, 4 weeks or with some treatment. So if you look at the barriers, first barrier is your withdrawal symptom, which happens in first at least a week to month. The most significant barrier, as mentioned, is craving. So withdrawal symptom and craving. So your treatment should target about these two symptoms. If we can handle these two symptoms, the chance of successful coming out of tobacco is very high. Now let's look at data about quitting. Now with self-quitting, 33% of smokers are abstinent for 2 days, and only 3 to 5% for 1 year, which is abysmally low. But at the same time, look at the pharmacotherapy last 5 years, 8 years, 10 years, what it did. It actually double or triple the chance of quitting across literature, across country. Also, don't undermine the willingness of the patient or client. All tobacco users, they do make quit attempts. You can see the case we discussed, who is a chronic smoker, still he tried to quit, but eventually 50% can quit. And most common reason, as I mentioned, stress relief and enjoyment, which makes them relapses. Now, why, in spite of knowing that pharmacotherapy can double or triple or can increase the chance of cessation to 50 to 70%, why not people are using pharmacotherapy? As I mentioning in the developed country also, the hardly 10% of people are getting the benefit of pharmacotherapy in spite of resources being available. In spite of this, most of the agents are over the counter. You can walk down to a pharmacy and get all the medicine. You don't need a prescription per se. But why is not working? Probably first point, I think, limited availability of pharmacotherapy. At one point of time in our country, only gum was available and nothing else was available. And obviously, across the world, everything is available over the counter. Now, fortunately, things are better and we have more agents. Now, second point is very important: limited knowledge of pharmacotherapy. Along with knowledge comes experience or wisdom. Little experience of using proper pharmacotherapy. And the fourth point also is very interesting. Nothing works. Come on, this is smoking, so nothing will happen to this guy. Just quit. So therapeutic nihilism. And last part, obviously, that whether tobacco users want to use pharmacotherapy or not, that is one hesitation from their side. If I divide the pharmacotherapy into broad headings, these are two things. First one is nicotine replacement therapy, we call it NRT. We have gum, inhaler, lozenges, spray, patch. Now how it works? It supplies the nicotine but eliminates other harmful chemicals. Now you should always remember nicotine is clubbed with almost 4,000 carcinogenic chemicals which are actually deliberately put to make the delivery system faster. So at least here you are giving the pure nicotine. And what else happens? It decreases the intensity of craving and withdrawal symptom. I mentioned that craving and withdrawal symptoms are two major barrier of stopping alcohol, stopping nicotine, and probably it may provide similar effect in sense some degree of betterness in the mood. So non-nicotine therapy, we have Varenicline, bupropion, nortriptyline, chloridine. There are many more. I thought keeping confined to these four. Now, how they work? They work in a central nervous system. I have spoken about the receptor. They actually work in the receptor level. I'll come back and speak in detail. Now, let's before we go, let's ask the question: does NRT work? Always a dilemma discussion among all of us. Does nicotine replacement therapy work? Till now, 132 randomized controlled trial has done across the world. 40,000, minimum 40,000. There must be plenty of open label trial and all. 40,000 participant has reported that NRT significantly increased the likelihood of tobacco cessation compared to placebo of the risk ratio of 1.58. Now, it may not be looking very great, 1.58 times, but again, looking at a huge public health problem where you don't have a very good pharmacotherapy available, the disease which is a combination of biology, environment, and other factors, this is a pretty acceptable number. Similarly, you can compare between gum and spray. The overall risk of long-term smoking abstinence with different forms of NRT varies from 1.43 to 2.2. So there is a, in one level 1.43 to as many as double. See, 2.2 means if you give a placebo versus a spray, the chance of person quitting tobacco is twice. Coming to Cochrane review, so NRT increases the long-term quit rate by 50 to 70%. This line is very important, irrespective of the treatment setting and counseling. So it doesn't matter, you give intense counseling, brief advice, brief therapy, multiple sessions, single session, OPD patients, indoor patients, dental clinic, any clinic. If you use NRT, you have the chance of success of 50 to 70%. It's a Cochrane review, which is considered to be standard across the world. NRT users were twice as likely to remain off tobacco compared to NRT non-users 4 years after treatment. Again, these are the pointers that one should definitely go and give the NRT irrespective of the where he practices or what type of intervention he can do. Now, these three, as I mentioned, are at this point of time are available, and I'm pretty sure most of you must be using this treatment in your practice. And of late, latest was fetch, which we have started using in our practice. One thing I want to emphasize, while using these agents, one should be very particular about this standard practice of using agent. One of the failure happens when you actually have not decided by yourself or not confident by yourself how to prescribe and how much to take. So that is one of the reasons of people relapsing. So gums are available 2 and 4 milligram. Unfortunately, 50% of gum is bioavailability. It means each person take 2 milligram of nicotine gum, only 1 milligram goes into the blood. But that is a limitation of our body system. Now, if somebody is low dependence, again there is no stringent criteria for low dependence. I'll come back and tell. But if clinically feel is low dependence, you start with 2 milligram. High dependent 4 milligram. Now, what is the practice? You advise first to stop all tobacco products. Now, this is the standard advice. You start with 1 gum every 1 to 2 hours for the first 6 weeks, then taper down slowly. So basic thought behind that: the first 6 weeks, as you saw the graphs, withdrawal is very high, craving is very high. So give adequate dose. It means every 2 hours you take out the 7 hours of sleep. So you have got 17 hours. 17 hours means almost 10 to 15 gums is a must, one per day to actually adequately control the person's, Again, there is the option of using additional gums if you want. Now, regarding chewers, is a very difficult group. The smokeless tobacco users, at least in our country, they know nothing means standardized yet that how much they need. But our experience in this is that about half is enough for the chewers, unless it's very heavy chewers or you're facing some problem. Half the dose is all right. I just thought I will put this verbatim. When you persuade a person to start gum, nicotine gums are effective in helping you to deal with withdrawal. I recommend that you use 2 or 4 milligram as per your decision. To start with, you can use one gum every 1 or 2 hours of the day, and in between whenever you have urge. And you can then tell this is how you should use it. I think, as all of us know, it's chew and park method. I deliberately highlighting these points because this is where we all go wrong. First step, continue chewing the gum till you get a pippery test. About around takes around 5 minutes. Stop chewing, keep in between the gum and cheek. Give around 10 minutes time so that nicotine from the gums gets absorbed. Can shift to other side to the mouth and chew slowly, and continue this till next half an hour to 45 minutes till the pippery test stops. So this is the standard advice for anybody who is studying the gum. Again, tell them to avoid cold drink, juice, and all for at least 10-15 minutes before after. I mean, it's not a contraindication, but it's advisable. Last point: no, don't be miser in using gums. I mean, I've seen again and again with our residents and my different classes. People will give gum, 1 gum, 2 gum, 10 gum. Not work. Look at a guy whose body needs constant supply of nicotine. And if not, you can look at the Barack Obama's clip in when he came to meet Modi, and he has a gum in his mouth, so which is nicotine gum. So it means gum has to be always in the mouth. I tell the patient, you always keep a gum in the mouth, at least in the first 6 weeks. Otherwise, don't take a risk. The case which has been discussed now, the situation could have been avoided if you would have cleared the lozenges when you went outside, and you could have coming in the meeting when you actually lapsed. You could have taken a what you call lozenges. Right. Now, somebody is asking about adverse effect. First of all, it's well tolerated. We have given thousands and thousands of gums. We have never heard. Now, there is a acceptability might be poor, but there is no side effect per se. Some people probably may complain of soreness of mouth because of continuing to chew it. But again, those also slowly they develop tolerance, and it's just part of a normal gum. Normally reassure them, tell them to chew slowly helps. A lot of people actually chew very fast, like center press, go on chewing it. So all nicotine comes out. So once you chew so fast, the nicotine gel in center comes out, then it leads to spitting. I mean, basically nicotine causes a lot of saliva secretion. But go slow, that's important. Okay. Now this is a new one for last 1 year is available in the market. The market is a pastille in our country, but actually it's lozenge. It's a jelly. It's like a dark color jelly chocolates. So again, the dosage are more or less similar. Again, the higher dependence 4 milligram, low dependence 2 milligram. Not much of. Only thing here you allow to dissolve. So unlike gum, you don't have to spit here. It dissolves completely. And here you keep it below the tongue and roll in the tongue and keep in the mouth. You don't have to put it on the. It doesn't have to be parked somewhere. You can roll it through the mouth. Again, not to drink. Only good part of the gum is that the bioavailability is a little better. So almost 25 more nicotine than the gum. So if you use the pastille, probably you might have to give lesser dosage because more nicotine goes to the body compared to the gum. Now, this is the third one. I thought this is the latest one. Now, the advantage of nicotine patch is there is simple to use and better compliance because one patch has to be used per day. The slow and sustained delivery of nicotine. Nicotine levels are typically half those obtained by smoking. Now, this may be issue. I mean, we have a couple of percent we are struggling with this part. In spite of using a gum patch, the still complaints of craving in between, and then at that point of time we have to supplement with the with the gum or lozenges. At this point of time in our country, there are three strengths are available: 7 milligram, 14 milligram, and 21 milligram. You can get a chemist shop. Now, normally you start from 7 milligram per day, then you can increase to 14 milligram. But if the dependence is very severe, you can definitely start higher doses, that is 14 milligram patch per day, and can go to 20 milligram. I mean, in our experience, I don't think we get good result in 7 milligram till now, correct? Most of our clients actually require 14 to 21. I mean, we hardly get 7 milligram. Probably 7 milligram is useful in titrating down rather than titrating up. So when you're titrating down, that time 7 milligram patch will be more beneficial. But we have not yet titrated anybody down yet to do it. Once it then once daily usage, uh, there is no major effect side effect. I mean the cases where you have used, it didn't find any problem. Yeah, breakthrough craving, you might have to add on with something else. This is a small picture where I think I thought of showing you where to use patch. You can see that first one, left one. This is actually the instruction sheet inside the inside the nicotine patch. You can see that also. Basically, non-hairy part. It has to be any place. And this case, which actually printed last time, where this gentleman is using a patch in the left, chest area, and this was actually 21 milligram patch. It's almost like transparent, cover, transparent polythene. Right. Now the question is, what time we should use the patch? Is it day or night? Now there are a lot of debate on that. Some people tell that night they might be insomnia. Some people tell day, but normally we advise to use throughout the day, and night being the sleeping period. Don't worry, but if can continue, he can continue throughout day and night, not issue at all. So it's not contraindication to use. Inhaler, I'll just touch on this. This may be available very soon in next 6 to 8 months by multinational companies in India. Only good part of inhaler is like a smoking. So we have like hand to mouth ritual, which you get in smoking. Each cartridge contains 10 milligram nicotine, and 4 milligram is delivered and 2 milligram absorbed. Again, 6 to 16 cartridges for 12 weeks and taper down. Again, results looks better than placebo. Nasal spray, it has, as being in the name, it has to be given through the nose. One spray of equal to 0.5 milligram of nicotine per nostril. Blood nicotine level peaks within 5 to 10 minutes. It can start with low dose and higher dose and can decrease later part. Now, only advantage of the spray, the highly dependent smokers benefit more than the spray. I'll come a graph where you can see the spray, the peak in the spray, peak value of nicotine in the spray is much higher than the other things. And this is the graph. So you can see here comparison with the cigarette, patch, gum, and spray. Now look at the cigarette. Obviously, as expected, there is a rapid peak. That is the blue color and trough. Which is similar to the light blue in nasal spray, where you are getting not as a high peak, but definitely there is a peak and coming down. And patch and gums are more or less similar, but patch, the advantage is that it starts slow and maintain a steady state, whereas gum, it goes up and goes down. So probably patch may be superior to gum definitely in some people. Now here is just to depict how NRT works here. So in a person who is smoking, he passes through repeated peaks and troughs. You can see the pink color, and the NRT able to try to maintain the nicotine level in the blood and preventing these troughs and peaks. If I can summary, this is a summary slide of the gum and patch. The slides will be available. You can definitely look at the resources are standard resources. In gum and lozenges, dosage is similar. We have to give 2 milligram for low dependence, 4 milligram for high dependence. Total duration of therapy is around 12 weeks to 16 weeks. The chew and park method I have already mentioned. Usually safe. The advantage is that it affects it very well in control of withdrawal symptoms. Second good thing about the gum is that even concomitant use of tobacco does not cause any significant problem. Because you will definitely come across a situation where the person does not want to stop tobacco, and even you can negotiate with him. If you want to reduce, you should still go for giving tobacco, giving nicotine NRTs. So that means it can be initiated without complete stoppage of tobacco use also. Nicotine patch, more or less similar. So more than 10 cigarettes, you go for 21 milligram. Less than 10 cigarette, 14 milligram patch. Used for 10 to 12 weeks. Apply in the clean and non-hairy part. Easy to do, and it provides a steady level. Now, question is how long to give? This is a very common question. All of us, ask ourselves, how long I should give the nicotine patch or gum? Now, although standard duration of the textbook mentioned about 12 to 16 weeks, but often it's not pragmatic or not realistic. Now, one option is that if the person is able to get a good control over this situation, good control over the craving, withdrawal, start slowly tapering down, you can cut the gum into pieces, and even in between you can add non-nicotine gums, which works very well. So you can make 2 milligram gum, divide to 1 milligram or 1/4. But for heavy addiction, our advice is to go for longer duration. I mean, rather than taking a risk of relapse, you should go for longer duration. So this is small table I came across yesterday, that the duration of use of gum or NRT versus odds ratio of quitting. So somebody uses less than 4 weeks, abysmally poor. Somebody using 4 to 8 weeks of nicotine replacement therapy, the chance is almost 2.26 times. More 8 to 12 weeks, look at the chance, 3.84 times is the highest, and more than 12 weeks, around 3 times. So basically, the bottom line is here is that the longer you use, more chances that person can have a cessation or quitting. But this is the pragmatic, and when you sit in the clinic and treat your patient, this is how it is. Let the individual guide you, because the user is the best person to help to decide and increase or decrease in quantity or frequency of use. So don't be in some sort of fighting that you should use this much, should not use this much. Let come to common theme and practice that one. Can you combine NRT? Yes. Although standard practice is that you use NRT, we have spoken again and again that we have combined patch with the gum, patch with the lozenges, and the study shows that NRT combinations versus NRT monotherapy, I mean the chance of recovery is much higher in combination. Okay, let's finish whole thing.
I think we have one question for I think we have questions about whether from the NRI Medical College about whether they can use e-cigarettes as NRT. I think that's
okay. I'll take some discussion. I think it's very valid point. Yeah. There are debate going on this one, pro and cons. But let's finish the standard one, which is the standard operating practice as a clinician. So let's come back.
I think we'll take two questions about this. One is about that again from the dental college. They are asking about the incidence of temporal arteritis in smokers because they have a patient with severe headache every time they smoke. They're wondering about the relation of nicotine to temporal arteritis. And additionally, Dr. Ashwini wants to know how many patches to use for a patient to use 18 to 20 gutka packets per day.
Right. I think excellent. Thanks both of you for the questions. I think temporal arteritis, yes, it's associated with the nicotine. It associated with nicotine use. It worsens with nicotine use. There's no doubt about that. Regarding the second question, patches. Now, unfortunately, as I mentioned, you don't have equivalent thing. But somebody using 10 to 18 to 20 patches,
18 to 20 gutka.
I will put him in the high level of dependence. 18 to 20 packet of gutka means whole day he's putting a gutka in his mouth. Take 18 hours. That's how it is. So definitely, if fulfills the high dependence, I will go for 14 to 21 milligram of patch straight away. And I mean, even I use the higher, nothing harm in that rather than taking a risk.
Additionally, the patch isn't great for breakthrough craving. So for somebody with this much of a high use, you might want to consider using both the patch along with breakthrough, either pastilles or gums for breakthrough craving.
And also pharmacotherapy. I mean, there is option available because see, higher the craving, the difficult to manage. You need to understand that point. Now, I will speak specifically this agent, which is more scientifically proven and definitely has been great use. So this group of molecule is known as PNRA, partial nicotinic receptor agonist. I mentioned there alpha 4 beta 2 nicotine acetylcholine receptor agonist. There are three agents available. At least Varenicline and cytisins are available. Dinacline is not available. It's been out of the trial. But Varenicline and cytisins are available. Cytisins are available online in some in our country also, but is not yet approved. There's a story behind that. Sometime we'll discuss, or in discussion we'll tell how drug company do manipulate, and I do not call manipulate, how they take the molecule and market, and it's like marketing water. So we'll come back and speak about that little later. So Varenicline is a partial agonist of alpha 4 beta 2 receptor. It's composed of 2 alpha 4 and 3 beta 2 subunit receptor. Now, how it helps? It helps in prevention of withdrawal because it agonist and decrease the reinforcing effect of the smoking by antagonizing it. I will come back and let you know. Just I want to mention here, being a partial agonist, it does release dopamine. Like if nicotine releases the dopamine, dopamine is that efficacious molecule which gives you kick or pleasure. So if dopamine is 100% released in nicotine, here it's 30 to 65%. If I just go back a little bit and show you how it works, this is the receptor which is located at the ventral tegmental area, and this person smokes nicotine, who goes and attaches to this receptor and releases the dopaminergic the yellow bubbles are dopaminergic chemicals, and which leads to the pleasure. Now, Varenicline was approved in 2006 by US FDA. It's derived from natural chemical known as cytisine, which is found in the plant false tobacco. Unfortunately, cytisine, a plant product, has been being used by a lot of European, East European countries for years together. I mean, so and so that anybody want to like herbal therapy, anybody at the family is smoking tobacco, they'll go and give. Why don't you take a cytisine plant? It's plant leaves. Now, because it has been used by Eastern Europe, where language there's no English is not a major language, so a lot of research papers has been not been published. And after knowing that a multinational company look at the cytisine architecture in the lab, and then from the cytisine they derived the molecule varenicline. So but actually cytisine is almost free. I'm looking at it's the brand name is Tabex, Tabex. Tabex is the brand name, and I look at the cost online. It's hardly must be 10 rupees, less than that. Whereas the varenicline is expensive. Okay, now how it works? Now look at this diagram where this alpha 4 beta 2 receptor is there, and this is nicotine. In normal circumstance, when a person uses tobacco, nicotine comes, sits over the alpha 4 beta 2 receptor and stimulate the reward pathway. Now, in case he is on varenicline, that's V, varenicline takes precedence and sits on that receptor and does not allow nicotine to come close to the receptor. Doesn't allow space for nicotine to sit on the receptor. So what it does then means, if you take a nicotine, there is a full agonist, whereas the varenicline is partial agonist. So it stops withdrawal symptom because it's not antagonist. So it releases some dopamine. Also, it decreases craving because being agonist, it has similar effect as nicotine. Whereas now, if that person who is on varenicline smokes or uses tobacco, the receptor is not vacant. The receptor is occupied by the varenicline. So the pleasurable effect of natural nicotine he cannot achieve because that place is already blocked. So then it blocks the pleasurable effect of the nicotine. If I summarize, being a partial agonist, varenicline stops the craving and withdrawal symptom, as well as blocks the reward of any externally taken nicotine or tobacco by the smoking or chewing tobacco. So this is how it works. Now it's a pretty decent drug. I mean, look at the bioavailability, more than 90%. So compared to the other drugs, 50% now. And also, best part is that it's not affected by food or time of dosing. So you can ask person anytime he can take. A good absorption can be taken with or without food, so no problem. It follows a linear pharmacokinetic property. It means you can predict the blood level of varenicline with the dosage, and it's standard across all population. So don't worry about that. Some people have higher metabolism, less metabolism. Protein binding is low, so drug interaction is less. That means even if a person is taking other drugs, definitely there's no contraindication. You can start the drug. Renal excretion is unchanged, and obviously it means those who have renal impairment, you need to adjust the dose, otherwise it's a very safe. Basically, the bottom line is that this is one of the very safe molecule, can be used and should be used more commonly by all of us. This is a dosage of the varenicline. First 1 to 3 days, 0.5 milligram morning time, 4 to 7 days, 0.5 BD, then 1 milligram BD. This is starter pack. You continue for 2 weeks. So the starter pack is for 2 weeks. Then you have continuation pack for next almost 3 months or 10 weeks basically. So the general rule is that give it for at least 3 months, give a complete course 12 weeks to get a best result. Now you have to prescribe it. Any of you, any practitioner can prescribe the medicine. There's no, it's not a scheduled drug. So like other antibiotic, other medicine you prescribe, can prescribe it. It is not usually recommended along with NRT because being a nicotine agonist properties, it occupies the receptor already, so may not work. But there are recent literature telling that in case of breakthrough craving, you can combine with gum or patches. But in standard practices, try not to give only Varenicline. Now let's look at the efficacy. Till now we have 15 randomized control trial which are almost 6,000 people, and it had been found as effective for smoking. Continued or sustained abstinence at 6 months or longer, the odds ratio is almost twice, 2 to 3 times. This is very interesting. Among Asian population like China, India, Philippines, Korea, they found much larger effect, like 46.4% in a placebo control study by Wang et al. So it looks very good. Now there is some concern about safety profile, but generally is very safe. Some people do complain nausea, but for our practice very less. Now in 2008 there is a black box warning given by FDA that it may worsen the behavioral change, agitation, or depressed mood and suicidal ideation. But a recent meta-analysis consists of 40,000 odd patients who are on Varenicline, and post-marketing surveillance did not support this hypothesis. And again, in our practice also, we hardly, at least I don't remember any case where a person developed this illness, and that too we prescribe to the people who are actually suffering from psychiatric illness because in our setting. But still, it's very important, if you are starting, do basically regulate the mood symptom, check about the mood symptom, especially if there is a depression or suicide in the family. I'll briefly talk about this part. This antidepressant, one is bupropion. Now this is an atypical antidepressant and has been one of the time tested drug for a long time. Start with 150 milligram per day, increase to around 300 milligram with time. Again, same duration is around 12 weeks. Now if around 6 to 7 weeks not working, you should discontinue. Now one other major problem with bupropion is the side effects are not very good, so a lot of people doesn't want to take it, and obviously those who have a history of epilepsy or seizure, it is contraindicated. Now efficacy is almost twice compared to placebo, and higher the dose, better it works. Also you can combine with one of the NRT, which found to be more efficacious than giving single agent. Now two other agents we spoke who are actually with studies has been done and very effective and very cheaper agents. Nortriptyline, primarily antidepressant. 6-RCT has shown evidence. Now side effects like dry mouth, postural fall of BP, sedation. So there are some contraindications, so you need to be careful that you are using. Clonidine, as Dr. Lekhan was speaking at that point of time, this is an alpha-2 agonist. It's actually an antihypertensive, but the meta-analysis shows that odds ratio is twice, which is almost equivalent to nicotine gum and other agents. But unfortunately, postural fall of BP has to be monitored. But if you can monitor properly, this agent can be tried. Dosage comes in microgram basically, so it's a 0.2 milligram to 0.4 milligram per day. But it's very cheap agent and it should be used by. If I come to the last couple of slides, the key recommendation in using pharmacotherapy: intervention that combine pharmacotherapy and behavioral support increases smoking cessation success compared to minimal intervention or usual care. Pharmacotherapy for tobacco dependence treatment is safe and effective. As I have mentioned again and again, it increases chance of quitting. NRT is very safe and should be offered to all patients, but in a proper dosage and duration. As I mentioned before, the effectiveness of NRT is largely independent of intensity or additional support provided to the individual. So that again means that wherever you are, whichever setting you are, you should definitely go for NRT. Combination of multiple NRT increases the smoking abstinence This is very important. Now, you should definitely consider treatment even if the person is not willing to stop very firmly at that point of time. Bupropion and norepinephrine are effective agents for CSM. Now, Varenicline is the most effective agent at this point of time available in the market for smoking cessation. 1.5 times more than bupropion and twice more than NRT. So it again depicts how effective it is. There is a concern regarding Varenicline association with neuropsychiatric behavioral changes, but this should not be a reason to not to write. Only to be cautious. And norepinephrine, clonidine, and cytosine may be the low-cost treatment option available at this point of time. Okay. If let's look at only counseling, any of you do a individual counseling, the odds of quitting is 1.39. Telephone quit line has been very effective in this area, 1.37. And a physician, physician means dentist, doctor, anybody, who just give a very brief advice. See, look at the rate of response, 1.66 times, and there is 17 study to prove it. And brief counseling, which obviously brief advice probably will be take 1 or 2 minutes. Brief counseling takes little more than 10-15 minutes. Is little higher. So what I'm trying to tell you is that anybody come to you, don't leave him. If you have time constraint, give brief advice. Little more time, give brief counseling. Now, if as I mentioned, you should definitely use one of those. You can see the strength of evidence means how strong it is with meta-analysis, RCTs and all. Hence, everything is A. Any NRT, the chance of quitting increases almost 1.5 times. You can see gum, pets, spray, lozenges. Bupropion 1.69, Varenicline 2.27, and norepinephrine 2.03 and 1.63. So this basically shows the effectiveness of pharmacotherapy in the management of patients. Now, how you decide? Now, there is no stringent criteria to decide what to give, but this is a blind rule. Now, somebody using nicotine within 30 minutes or using more than 20 BD cigarette gutka or score higher than 6, he needs can be classified as a high dependence. So, as you discussed before, high dependence needs more than 20 gums or things. So, similarly, pharmacotherapy should be strongly recommended. All persons with severe dependence, again, it's a clinical decision. You decide. You ask him, do you think craving is very significant? Are you using a lot of tobacco? Also, tobacco users with multiple failed attempts, and those users who are not able to be abstain, even the low users, with only brief intervention. Other indications like adverse effect, medical contraindication, psychiatric comorbidity, concurrent medicine, cost, those are important. But with the available pharmacological agents, almost all are very friendly and very, without any major concern. Okay, so this is a 5A, which I thought last part of my slide. Ask, assess, advise, assist. So pharmacotherapy comes in assist. Assisting the person with counseling, medicine, and obviously follow up and look at the follow up. At a conclusion, nicotine dependence treatments are effective in reducing relapse, increasing abstinence, and increasing quit rates. But many patients still require multiple attempts to quitting. So pharmacotherapy can double or triple the likelihood of successful smoking cessation, but it is not a magic bullet. Don't go with the impression that pharmacotherapy is going to cure completely. It's a combination of 5A, brief advice, brief counseling, with a judicious pharmacotherapy, which actually going to help the client. I think I stop. Thank you very much.
Thank you, sir, for this very informative and comprehensive presentation. I think this opens up a room for everybody of us to clarify what doubts if we have and ask questions. Mostly you can ask questions by chat, or if you want to ask questions, you can ask.
You can unmute and ask.
Go ahead.
I think perhaps we could take up the e-cigarette question
Right.
at the launch.
So the question was whether e-cigarette can be a part of a harm reduction, mechanism. I think who got the question?
This is from NRI Medical College.
Yeah.
They use e-cigarettes as
But I mean, again, I am not the expert clinically, because I have basically not seen much case of e-cigarette. I have seen e-cigarette. I've gone inside these shopping malls in most part of the country, Europe and America. But I don't think. Have you seen any case of e-cigarette till now? I mean, I don't know.
We have
Few cases you
at
seen?
least Varenicline has stopped with these.
Oh, that's good. No, I think this debate has been very prominent now. See, when it started, e-cig, people are very skeptical. No, it's not good, and this and all. But if you see latest, I think 2015 JAMA or somewhere I just read recently, there are actually serious talk. Can e-cig be a harm reduction for very highly dependent? Because the advantage in e-cig that talking about, it gives the pure nicotine, which is like nicotine gum and its lozenges. So that is advantage. But I think, I mean, just one or two report has come up recently. I think one study has come in addiction, or this year addiction has come up, where they found that highly dependent people can get benefit with e-cig is a hybrid strategy. But anybody can. It's open for anybody who comments from any our participants. You can you can unmute and go ahead.
Dr. Anand has a comment. He says that CBT helps in the management of stress and anxiety, and craving can help in controlling.
I think I completely agree with Dr. Anand. I mean, we actually we didn't take off, but definitely no doubt that CBT and relapse prevention skills, focusing on the person's difficulty, definitely it goes a long way in helping you. No doubt about it.
Just to come back to the e-cigarette point, I think one thing that we probably should keep in mind with the e-cigarette is that the WHO has not recommended e-cigarettes as a form of NRT currently because the long-term effects aren't. That's been one of the biggest factors in which people. Some of the other problems that people have had with the e-cigarette has been that whether it acts as the new gateway to smoking as well as other drugs because of its availability in supermarkets and availability to teenagers and adolescents. Whether the first use of nicotine occurs earlier or not, but those are more policy level issues than anything. But in terms of actually prescribing them, the questions have been about the use of the formulation for delivering the e-cigarette. For example, when you deliver the liquid containing nicotine, there have been questions about whether existing of formalin, for example, has been could have long-term side effects either on lung or in terms of locally in the mouth over time. And those questions haven't been answered yet. So that's why there is no recommendation yet on the e-cigarette. Though there have been some reports in addiction and JAMA, etc., that there have been some efficacy in terms of e-cigarettes, comparable even sometimes to spray, better than patch as well.
I think one thing probably, I mean, I don't know whether any of you experienced of using cytisine. Any of you have started using cytisine by any chance? Because it's being around in the sense, not officially, but definitely because it is too old molecule to pass through FDA and all sort of what you call different classification. But in case the reason I'm telling it's very cheap. I mean, there is that appeals to me a lot. I mean, I don't know whether you know the cost of Varenicline. I think 1 month, how much? 3,000? 3,000 rupees a month. Less now, okay. Which obviously in our country, our people who we see impossible, and this is the exact derivative of cytisine, which is almost free. Actually, cytisine in the European country it's free. You can just plant. So there is one debate in the tobacco journal last year where the people has very strongly wrote about the Pfizer which produces Varenicline and how they could have done much better job getting more people under the rubric. I mean, you make drugs so expensive. A smoker cannot or can never able to afford the drug, and you wait for cytisine to go through the trials and come to market. You lose so many people dying in the whole thing. I mean,
I think one question we can probably take up is from Dr. Shobha Shah, who says that she's working with an adolescent age group and chewing tobacco is common. And what's your advice for quitting tobacco? Will gums be useful? I guess there's an additional question: is in adolescent age group, what is the recommendations for?
Anybody want to take up this question and Dr. Sobha's question? I think very pertinent question. Adolescent, a vulnerable group, difficult group. Any advice? How she will help the? You can unmute and go ahead, sir. We want your advice. We are not expert. I mean, we ourselves has limited experience. Dr. Anand, do you have an advice for adolescent group using tobacco? Do you think you can?
Dr. Anand, you can go ahead.
For the time being, I'm not coming in.
I thought I have some experience. Right. I think I also don't know actually. I can ask my adolescent colleagues, child and adolescent mental health colleagues, and get back next time, next session. Because what is the best for adolescent? I mean, anybody can chip in. Deepak works in adolescent. Deepak.
In terms of harm reduction model, there's no doubt that chewing tobacco the chewing tobacco or smoking forms of tobacco are more harmful than using NRT or more. So in that sense, using NRT would probably be a good option to start off initially with adolescents. In terms of how Varenicline is and bupropion is, that's a little bit of a thorny question. With Varenicline, there's no special warning for adolescents that's there. However, again, the same corollary would apply. You would have to look for mood symptoms over a period of time and ensure that the caregiver is aware that such risks may occur and is able to look at them. In terms of bupropion, that's a little bit of a trickier question because in terms of bupropion and its effect in adolescents, again, prescribing as NRT or not, that again is not clear. So if you want to, in adolescents, perhaps trying NRT would be more acceptable than say trying bupropion and varenicline. And in cases where NRT was not enough, we could consider trying varenicline with adequate consent and adequate one.
This is a very interesting point Dr. Mule has pointed out. I think thanks, sir. Dr. Mule is from Pune, and thanks, sir. I think his point is that for teenagers, a course of Vipassana of 7 days has been devised, have been useful. Yeah. Correct. So I think there is a pretty good amount of literature available for this alternative and complementary form of therapies, including acupuncture, are useful. But I think that's a good thing. I mean, whether do any of you have any experience about alternate therapy like yoga or meditation or vipassana in nicotine users? I was very curious to know actually. I mean, do you have any literature in our country?
But just to maybe draw a corollary, for example, in the study done by Nimans and child psychiatry on solvent users, for example, in an adolescent group, enhancing life skills did help to a significant extent in cutting down solvent use even without directly addressing it. So, for example, life skills approaches and nothing can serve as play a significant role in helping cut down. Especially the teenagers themselves are motivated to it.
I think that Asin's point is very important that when you work in a group, like it is mentioned, like a play therapy or group therapy, in adolescent, definitely helpful. Yeah, but let's go. I mean, let's go back and search. Do you have any specific? Let me search next time. I can come back with this question that whether actually something is really been tested. Adolescent.
Another question again is from Dr. Ashwini about what is the best choice for community centers. Basically, she's saying for an OPD only setting, which is the form of cessation you would recommend with the least side effects.
The OPD based therapy?
For an OPD based setting where inpatient admission is not possible, which are what form of treatment would you recommend?
Inpatient or
no, outpatient. Her setting is an outpatient setting in a community. What is the form of treatment she should be able to prescribe without any fear?
I think, first of all, I think as you mentioning, you need to take a call whether you need to give pharmacotherapy or not. Now, the blind rule is that if you feel person's addiction is very severe, please go for pharmacotherapy. I can see nicotine gum, patch, and lozenges all are over the counter. It means they're so safe that anybody can use. So I think you can go for any three of that. Medicine also can go, but I think the medicines need little supervision and cautiousness. Even we also use very less pharmacotherapy and tablets. Only when there is a failure in the first line, or person is under supervision. So if in OPD based, I will definitely NRT, nicotine replacement therapy, you should go ahead and do it.
Dr. Saurabh also, just to add on to this point, says that there's been a recommendation for adults in smoking must include both primary prevention and cessation, and that bupropion NRT, including all things, have been studied to a limited extent, and should be individualized and combined with psychosocial behavior.
That's right. I think absolutely, but that should not undermine of, should not pull you down of using NRT. This is the biggest challenge in our country we faced for last so many years. The reluctance of the therapist to write pharmacotherapy. So that I think the basically, if you ask me, the take-home point of whole thing, one should not be reluctant to use. Then obviously you use judiciously and condition, but don't be reluctant to use. Where there is need of use, you should definitely use it. Let me go that slide.
One more question, which is an interesting one again. That Dr. Neha Lodha wants to know if, I assume psychologists, could they prescribe cytosine or varenicline?
No, at this point of time, both are on prescription only. They are not over the counter. And see, it's not that you cannot prescribe, but they need some supervision, particularly Varenicline. Definitely, prescribed medicines should not be encouraged. But again, once you prescribe, each person need to monitor. For example, when I start Varenicline or we start Varenicline, we actually call him every almost a day or 2-day interval. We take a detailed history. Then it is a process. I mean, I will discourage you to use.
I would like to add to it. I'm Lekhansh. Actually, FDA in 2013 gave an advisory about Varenicline, which is sub judice right now. I mean, sub judice as in the jury is out for it. It said there is increased incidence of mistakes while handling machinery. That is one. And perhaps some amount of increased acute cardiac events. But then the sample which has been studied post-market till now is not the strength is not good enough to substantiate or to refute it. So probably there's more to Varenicline which might come up eventually.
I think I completely agree with this cardiac event. I deliberately didn't present. I mean, see, look at this tech involved in Varenicline molecule itself. It's a high cost molecule for a public health problem. So there is a lot of conflict of interest between the company, FDA, data collected. So I mean, each time you read the literature, you could come across so many issues. So I will strongly tell. I mean, if you want to Varenicline, start Varenicline, take a help of a psychiatrist or chest physicians or cardiologists who are writing Varenicline and they've seen the patient. It's a good drug, but it has to be cautious in using. It should not be counterproductive. That's all.
Dr. Sultana also asks if we can combine NRT and non-nicotine drugs.
Yes,
and how best to combine.
Yeah, the best combination which we used before Varenicline came to market is bupropion plus gum, bupropion plus patch, clonidine plus gum, clonidine plus patch, nortriptyline plus gum plus patch. So I think you can definitely combine. There's no doubt about that. But again, whether to combine it at the beginning or at the course of the treatment, that decision you have to take as per the patient condition. So somebody who is severely addicted and you want to start bupropion, then you start both. Start bupropion 2 weeks before quit that, add on the gum after 2 weeks.
One additional thing probably should know is that in terms of availability of gums, 2 mg gums is quite widely available.
Yes, over the counter. Right?
Over the counter.
Yes.
However, if you're trying for the 4 mg gums, sometimes there you might actually require a prescription to actually access them because those aren't available over the counter. So if you're going to prescribe to somebody 4 mg gums, they need an actual prescription from a doctor. If you're going to use 2 mg gums, you might have to use more gums to achieve the same effect.
Any experience on using lozenges or patch? You want to share?
You can unmute yourselves and go ahead.
Yeah, you can unmute and please let us know.
And Dr. Parneet has a question who says that she has a client who smokes about 20 cigarettes a day. Dr. Parneet, you can go ahead.
Dr. Parmeet, you can unmute and I mean it will be audible to all the participants and so that you can have a better inputs.
I've unmuted you.
Yes, sir.
Thank you.
Can you hear me?
Yeah.
Yes, I have a client who smokes about 20 cigarettes a day, and she's also mentioned the hand-to-mouth ritual that you spoke on.
Mm-hmm.
And she also frequently makes use of alcohol. She says that as it helps her relieve stress and things like that. But that's not what she wants to work on. Wants to work on reducing the use of cigarettes, but also acknowledges the fact that she probably enjoys it and doesn't want to stop it completely. Maybe bring it down to 2 cigarettes a day or maybe one a day. So how do you suggest that I go about working with it?
What did they ask you how old this client is?
She's about 26.
Very young. Basically,
Yeah, and she started very early also. That's the thing that she started about, I think 16 or 18 was when she started.
and does he have a family history of substance use by any chance? You get a chance to?
Her father was a like heavy smoker. Like she says that her father was also somebody who smoked very heavy. But no other they're not like there's no other thing that I know of.
Right, right. Right. Any takers for this very relevant? Thanks, Dr. Parmeet, for such a, I mean,
Thank you.
nice question. I mean, it's really challenging thing. And any takers for this? So, yeah, we can summarize. Just mute your mic. So, you can summarize is a young lady, 26-year-old lady, who uses more than 20 cigarettes per day. And obviously, she speaks about hand-to-mouth ritual. Has alcohol problem, looks like, and a family history of smoking. She wants to reduce at this point of time, but doesn't want to quit completely. What is best practice for this client? Any thought about this case? Yes, I think. Any other reason? Anything?
First of all, she should be congratulated regarding the fact she has decided to at least bring down the number of smoking, if not completely. Then we should build upon that, because of the fact that even a mild decrease in the number of smoking can imply a huge benefit in terms of health implication in the long term. Now, the usual motivation intervention approach and the behavioral intervention should be applied. Now comes the issue of pharmacotherapy. Pharmacotherapy, of which I think the first line should be, as sir has said, in the algorithm and the approach, we should go for this NRT. If not, then we have to think of the other pharmacological interventions.
I think the question is NRT. Have you tried any of them, or see, there is nothing. There is nothing to choose in this case, but definitely he sees this NRT. Yeah, okay, not yet. And I think patch will be best for her. This is my feeling again. It's very wisdom based feeling. The reason I'm talking about patch because she doesn't want to quit tobacco. That means her brain is not willing to quit tobacco. If we can supplement with a constant level of nicotine to her body, pure nicotine body, chance that he will reduce it much faster and further. Then you can next step you can take out. See, for example, you give the patch, let's say 21 milligram. You can start 14 milligram because female normally doesn't tolerate 21 milligram. Start 14 milligram nicotine patch. Then after let's say for a week, 1 week, ask her nicotine use and ask the craving part. Now then you supplement. Do you want to take lozenges? Supplement with the nicotine pastille. Let's try these two. If it doesn't work out, then you can think of using other pharmacological agent. But I think it will be nice. You can, probably after 2 weeks, you can just give a feedback to us. We also want to know, this area. We also don't know what is happening. After 2 weeks, you can get back and let us know what happened. Nice. Yeah, nicotine patch for 2 weeks. Yes. Then after 2 weeks, nicotine patch plus gum. Sorry, not gum or lozenges. Gum or lozenges. Is nicotine patch available in your place? I'm not sure. Okay. Why don't you let's write a brand name and say. Okay. So there is only one company produces the nicotine patch at this point in the country, our country. We are sending in the brand name, but there's no conflict of interest. Don't think that we are promoting any of the companies. But I thought for our practice, what is the name? Tobacco needle. Okay. There is a company in Mumbai which produces the tobacco. We are using one. I think only company in India producing. So you can use that one. Lozenges, there are multiple companies are available in this country. Nicolange and Quitsure and so many companies. Right. Any other questions or suggestions? Okay. Dr. Yeah, I think Dr. Jennifer also wants the name. Okay. Okay, we are sending it because you don't want to get into the conflict of interest. We are sending to Dr. Jennifer and Dr. What's his name? Parmeet. Right. Okay. Right. Any other comments from other? I think. Kolol, your question I forgot. Dr. Kolol, can you just go ahead again? I didn't.
So I wanted to know whether there were any food allergy if you use any pastils or any lozenges. If there are any food allergy, because the symptoms are quite same as hiccups or any allergies, the skin irritation. So that are the similar symptoms what we see. So that time we don't know whether it is due to the pastils provided or is it due to the nicotine or any other substance.
Then I think the hiccups is because of nicotine. See, nicotine cause contraction of smooth muscles. So hiccups nicotine is not related to any allergic and all. Okay. At least what my knowledge, there is nothing, no contraindication or like nothing allergic is available when reported at least. But these are all local effects, and so one way to decrease hiccups is to ask them to take slowly, but take half. Sometimes I tell them to make 2 milligram half. Because see, what actually also happens, you realize when nicotine patch or nicotine gum goes to body, fast metabolism, and the cytochromal system is very active, and it varies from the different groups. And often you realize that the cytochromal system can decrease or increase the blood level of free nicotine. So making it half also works. Any suggestion?
In terms of the gums and the lozenges, swallowing tends to make people have hiccups or a burning sensation in the throat. This could also be because though the instructions say chew for 5 minutes, because 5 minutes is a little long.
Quite long.
Yeah, but sometimes people actually report that the peppery taste starts within 2 or 3 chews, sometimes more than 5 minutes. So when somebody's chewed for 5 minutes, what can happen is that they've actually had a large amount of release of nicotine, and nicotine itself is a salivary stimulator. So what you then have is that you have a large amount of nicotine containing saliva in your mouth, then you have to either swallow it or spit it out because you can't really talk otherwise. So in that case, just changing the way the person uses the tobacco gum might actually help with avoiding it. But these aren't allergies. Hiccups is not an allergic phenomenon. There can be local irritation with the patch. That is a known thing. Again, that's not a systemic allergy, that's local irritation. If that's happening with the patch, then you'll have to switch to another form of NRT or try a different site. But in terms of congeal causing allergies, offhand I'm not too aware of what the exact side effects are. There are people who had it.
Nicotex, the contents is a peppermint covering. Ulacrylex, which does not get absorbed, is only there for the binding, and gum arabica. And the sweetening agent used is aspartame. So for some rare cases of PKU, phenylketonuria, probably it might not be the best. That is the only thing in which Nicotex 4 can land you in trouble with.
And in terms of gums itself, for example, nicotine itself, when the person's been smoking already, they're not going to have an allergic reaction to nicotine. So if at all you're having any particular side effect or an allergy, it's probably to a congener. And if that is so, then changing the form of NRT may actually help. Or switching, say, for example, if you found an oral form of NRT has an allergy, switching to a patch may actually help because of the different delivery and different congeners.
If there is no other questions or comments, I think, big bags. You want to take it up? Yeah. No, I think, I only spoke about the vaccine. Now, the current start of vaccine is that the phase 3 trial has been aborted, has been not continuing, but there are chances it will coming back again. If it comes, I will definitely let you know we're tracking on this information, and basically what is this we have spoke last session about the vaccine, known as nicotine vaccine. What does it mean is that you create enough antibody in the person's inside the person. So if he smokes a external smoking agent, those nicotine are not gone inside the body because they're being trapped by these antibodies. So there is a mechanism of Nivax, but I don't think we have very soon. I know it might take some time to look at the future of this one, but I think let's see how it works out. Okay, should we stop?
I think we have a question.
Okay, I think let's stop here. Thanks to all of you. I just want to make a small announcement that next time session is a panel discussion. We have got a panelist, a chest physician, we got a dentist, we got a policy maker who works for what you call tobacco control, national tobacco control program, and Dr. Pratima Murthy, who is one of the authority in the tobacco CSN program. So the 4 or 5 panel, we are trying to get a cardiologist, but still struggling to get his time to get it here. And so we have a panel of people who will speak about what they think in their perspective, and there will be interaction regarding policy level, regarding non-communicable disease, and psychological health and dentist perspective. So please join and participate in the panel discussion. And thanks to all of you. Thanks here.